In this video, I'm going to be going through skin and soft tissue infections. Cellulitis is an infection of the skin and the soft tissues underneath. Skin is normally a very effective physical barrier between the environment and the soft tissues underneath. When a patient presents with cellulitis, look for a breach in the skin barrier and a point of entry for bacteria. This may be due to skin trauma, eczema, fungal nail infections, or skin ulcers. How do patients present? Well, the skin will demonstrate changes of cellulitis and soft tissue infection, and these key changes are erythema, or red discoloration of the skin. The skin can be warm or hot to touch. It can be more tense and thickened. It can be edematous, with fluid collecting on the skin, and when fluid-filled blisters develop, these are called bullae. And a characteristic golden yellow crust can be present and indicate something called Staphylococcus aureus infection. Remember that Staph aureus causes this golden yellow crust. Impetigo is where you get a skin infection around the mouth or around the chin, and this has that characteristic golden crust caused by a Staphylococcus infection. So that brings us on to the causes. The common causes of skin infections are Staphylococcus aureus, and this is probably the one to remember as it comes up the most frequently. Group A streptococcus, mainly Streptococcus pyogenes. Group C streptococcus, mainly Streptococcus dysgalactiae. And MRSA is another key cause that needs to be considered, particularly in patients who are long-term residents in nursing homes or spend a lot of time in hospital. There's something called the ERON classification, which you should be aware of, as this is the classification system which NICE recommends for assessing the severity of cellulitis. Class 1 is where there's no systemic toxicity or any comorbidities. Class 2 is where there's systemic toxicity, so they're systemically unwell, or the patient has some sort of comorbidities. Class 3 is where there's significant systemic toxicity or significant comorbidities, which put the patient at risk of deteriorating quite significantly. And Group 4 is where there's sepsis or life-threatening infection. NICE recommend that you admit patients for intravenous antibiotics if they fall into Class 3 or Class 4, and also admit any frail, very young, or immunocompromised patients. So if there's any significant comorbidity or significant systemic toxicity, or of course sepsis, then they should be admitted for IV antibiotics. Which brings us on to the choice of antibiotics. Flucloxacillin is the one to remember, and it's very effective against Staph aureus infections, and it also works well against other gram-positive cocci. It's usually the first choice in treating cellulitis, particularly if they're being treated in the community and it's fairly simple cellulitis, but flucloxacillin can be given orally or intravenously. Alternatives to flucloxacillin are things like clarithromycin, which is a macrolide and can be used in penicillin allergy. Clindamycin is also very effective and has quite a broad spectrum of antibiotic coverage. And coamoxiclav can also be used and has a broader spectrum of bacterial coverage. But remember, it's penicillin based, so it can't be used in patients with penicillin allergy.